All right, once again, welcome everyone to our STI XR webinar on male partner treatment to prevent BV recurrence, evidence and implementation. Again, I'm so happy to welcome Dr. Kat Bradshaw, who's with us all the way from Melbourne, Australia, to talk with us about this important new strategy. My name is Kelly Johnson. For those who don't know me, I'm the medical director of the California Prevention Training Center at the University of California, San Francisco. I'll be starting us off just going through some introductory slides and some basic information, and then I'll turn it over to Dr. Bradshaw. So first, a little bit more about us, the California Prevention Training Center at the University of California, San Francisco. We are a multidisciplinary training and capacity building assistance center. Our STI clinical training is sponsored by the CDC, and we're a member of a national network of other STD clinical prevention training centers. What do we do? Well, we provide virtual and in-person trainings, technical assistance, clinical tools, and STI clinical consultation services, all focused on complex STI issues in patient care. If you want to learn more about us or the network of which we're a part, you can check out the links on this slide. There is one resource I want to tell you about. This is the STD Clinical Consultation Network. This is run by the CAPTC for our region. It's an online clinical consultation network where you can go, you can submit a complex STI patient care question, and one of our faculty, all of whom are subject matter experts in this area, will respond to you in 1 to 5 business days, either by phone, email, or text, whichever of those you prefer. Now, on to some details about today's event. Here is our financial disclosure. We don't have anything to disclose. And here's our accessibility disclaimer, which essentially says that if you require this content in an alternative format, please contact us at the email address you see on this slide. Here's our CME disclosure, stating that today's training is offered at 1.25 CME units and there is no cost. And we do get a lot of questions about CME requirements, so I'm just going to go over this for you all. So to earn those 1.25 CME units, you have to do a couple of things. You do have to have registered on the NNPT site for this webinar by yesterday at 3 p.m. Registration is now closed. You also do need to attend today's webinar live and in full. Attendance is recorded as you sign on to the webinar, and we are unable to issue CME if you attend just part of the webinar. Third and lastly, you do need to complete a post-course survey evaluation by a deadline of December 23rd, 2025. This evaluation will be sent to your email 24 hours after the webinar. You'll get an email notification with a link to complete your survey evaluation. That will come from training@nnptc.org. It will come to the same email address you used to register for today's event. And to make sure you get this email, go ahead and add training@nnptc.org to your safe and trusted senders list, monitor your inbox, and check your spam and junk folders if you don't see this notification. Now for the CME notification, if you meet our CME requirements, you'll receive another email by January 25th, 2026, which will contain a claim link and instructions to get your CME certificate, which is through our CME provider, the University of Nevada, Reno School of Medicine. The CME notification is sent from a different email. It's captc@ucsf.edu, but again, it will come to the same email address that you used to register for today's event. To make sure you also get this email, add CAPTC to your safe and trusted senders lists and check your spam and junk folders. Now, you'll receive an additional email, a post-course materials notification with our slide handout, CME reminders, and any other available materials within about 2 weeks after today. You don't need to request these materials separately. They will just come to you. Again, that will come from captc@ucsf.edu. Now, a couple of quick housekeeping notes about Zoom. I think we're all pretty familiar at this point, but during today's webinar, the Q&A will be turned on for attendees, but the microphone, video, and chat will be turned off. Now, to use the Q&A, you just need to click on that Q&A icon that you see in the center of this slide. You can click on it, you can go ahead and type in your question, and you can click send. If you want to send your question anonymously, just select anonymous. You'll have up to the last 2 minutes of the Q&A section to go ahead and submit any questions. Now, during the webinar, I'll also be keeping an eye on that Q&A, and I may answer some of your questions directly there in the Q&A box, or we may save them to address them at the end of the session during the question and answer portion. You can also type in any administrative questions that you may have, and our administrative team, which today is Lauren Blakely, will respond in that Q&A box as well. If you have questions about today's webinar, you can reach out to our program manager, Elizabeth Olson, and you can see her email on the slide as well. Okay, now, without further ado, I have the pleasure again of introducing our speaker for today, Dr. Kat Bradshaw. Dr. Bradshaw is a clinician researcher and head of research translation and mentorship at Melbourne Sexual Health Centre, Monash University, and the Alfred Hospital. She has a number of accolades, as you can see on this slide, but her program focuses on translational research to improve treatment and control of STIs. And she has focuses both on antimicrobial resistance as well as interventions to optimize the vaginal microbiome, both of which I think could be relevant for our talk today. She has a really strong record of translating findings into policy and practice. She has more than 400 publications. She's a member of the International Society for STD Research, and she also is a technical advisor for the WHO. And I didn't even read everything. She's really done a lot of amazing things, and we're very grateful to Dr. Bradshaw for being here. And with that, I will turn it over to her. Thanks again.
Thanks, Kelly, and thank you to the California Prevention Training Program for the opportunity to talk today on one of my favorite topics. I'll just share my slides. Okay. So how's that, Kelly? Is everyone
Looks great.
perfect? Excellent. That's a nice smooth start.
Yes, good
So
work.
as Kelly said, I'll be talking on male partner treatment to prevent BV recurrence, and I'm going to focus on the evidence that led to the trial, including some pilot data, the trial itself, and implementation with a particular focus also on resources. It's always nice when you get a little bit of a glitch with your slides. So you just have to, there we go, bear with me while I just go back. Just going to end. All right, here we go. So firstly, I'd like to acknowledge the Boon Wurrung and Wurundjeri clans of the Kulin Nation, who are the custodians of the land and waters where I work, and to pay our respects collectively to elders past, present, and emerging in both of our nations. I don't really need to tell this expert audience how common BV is, but it might surprise some people to know that it does actually affect 1 in 4 reproductive age women globally. BV is obviously a dysbiosis characterised by a reduction in optimal lactobacillus species and an increase in bacterial diversity and anaerobes. Accompanying this, we see profound changes in pro-inflammatory cytokines, chemokines, the proteome and the metabolome. And this collectively increases the risk of acquiring a broad range of STIs, of HIV, of transmitting HIV, and of adverse obstetric and reproductive sequelae. The syndrome itself is also associated with significant distress and impact on quality of life and relationships. Now, globally, our recommended treatment has been solely directed to women, and this is either with oral or vaginal metronidazole or vaginal clindamycin cream for 5 to 7 days, and these regimens have equivalent efficacy of 70 to 80% at 1 month. But if you follow women, more than 50% quite rapidly experience recurrence within a few months of first-line recommended therapy. And if you look at women with an ongoing partner, this is as high as 60 to 80%. And we really haven't seen any significant improvement in BV cure for decades. This is largely because the pathogenesis and etiology has been quite unclear. No single infectious agent has been exclusively detected in women with BV and absent in women without. It's unclear if the event itself is initiated by a single or multiple pathogens, perhaps a founder organism, a pathogenic subtype of GVAG, or whether it's a polymicrobial consortium from the outset. It's also unclear if other factors triggered a decline in lactobacillus species, followed by an increase in BV bacteria, or whether it's the reverse. What we do know, though, is that published data very consistently show that BV has the epidemiological profile of an STI. So, numerous studies show that incident BV is associated with new partners and changes in partners, inconsistent or lack of condom use for penile vaginal sex, early age of onset of sex, and it is absent or rare in women who have not been sexually active with others. Conversely, when we look at recurrent BV, we see that being consistently associated across studies with ongoing exposure to a regular sex partner, suggesting that reinfection probably plays a significant role in recurrence. If we look at same-sex couples with two vaginas, we see really astonishingly high rates of concordance for BV, so in excess of 80%. We also have really robust evidence for penile carriage of BV bacteria and male involvement in the pathogenesis of incident and recurrent BV. So we see both the subprepucial space and the penile urethra harbour BV bacteria. They're detected more commonly at these anatomical sites in male partners of women with BV, and we see concordance for specific BV bacteria amongst monogamous heterosexual couples. The composition of the subprepucial and penile urethral microbiota is also influenced by sexual activity and male circumcision. And a nice study done by Supriya Mehta showed that the penile microbiota can be predictive of incident BV in female partners. Male circumcision has also been shown to reduce detection of these BV bacteria and the risk of incident BV in female partners. So, despite this really substantial body of evidence that female-only treatments have not achieved sustained cure for these reservoirs of BV bacteria in men and male involvement in BV acquisition and recurrence, why do none of our guidelines actually recommend male partner treatment? So, we've actually had 8 prior male partner treatment trials. 6 of the early trials, which were done largely in the 80s and 90s, were subject to 2 different systematic reviews, and they were found to have really significant methodological limitations, which I won't go into. But this was actually concluded to render their findings inconclusive. 7 trials exclusively only used oral therapy for men. An 8th trial undertaken in Kenya used a topical ethyl alcohol product in men, but all of these trials failed to reduce recurrence. Now, we'd hypothesised for some time that failure to use an intervention that targets both the urethral and penile cutaneous microbiota may have contributed to lack of an effect on cure in our prior trials. So we decided to evaluate the impact of a combination of oral metronidazole and topical clindamycin cream on detection of BV bacteria in the urethral and penile cutaneous microbiota of male partners of women being treated for BV, and to look at the impact of this concurrent combination therapy in males on recurrence. So we started with 2 pilots cautiously to look at the impact, immediate and sustained impact of concurrent male partner treatment on the genital microbiome of 50 couples. We looked at the impact on recurrence over 3 months. We got data on tolerability and adherence, and all of this was to inform the feasibility of an RCT. So these 50 couples in the pilots had an astonishingly high burden of risk factors for recurrence. This has been a bit of a theme in our studies. Obviously, desperate women enroll in these studies and you feel somewhat set up to fail. 84% of them had recurrent BV. Nearly a third had intrauterine devices. Now, this is 4 times that of the general Australian population. And for all the clinicians in the audience, they'll be very familiar with the fact that women with IUDs commonly experience quite recurrent BV. 80% of the males were uncircumcised. So we were fairly confident that we would have high recurrence rates in the order of 60 to 80% by 3 months. So this was a small series just to give us a little bit of an indication as to whether this intervention was likely to be effective And we were quite amazed to see that only 3 out of the 50 women experienced recurrence at 4 weeks. And this is comparable to women in our other studies and cohorts who either don't have a regular partner or are not having sex. Our 12-week recurrence in the second pilot that went through to 3 months, which was smaller, showed that only 17% of women experience recurrence. So it's really small numbers, but quite suggestive that and encouraging. We use targeted 16S ribosomal RNA gene sequencing to look for differences in the composition of the genital microbiota longitudinally across 3 anatomical sites in couples. So we looked obviously at the vaginal microbiota, the cutaneous penile and penile urethral microbiota. We measured this and looked at this at day 0, day 8, which was the day after treatment before couples had resumed sex, and at the endpoint sample. And this very simple bar chart here shows our taxa in orange and yellow. We have our lactobacilli. Importantly, Lactobacillus crispatus is yellow, Lactobacillus iners is orange, and we have our nasty BV bacteria in pinks and purples and mauves. So the take-home message from this slide, as you can see in the vaginal microbiota, lots and lots of BV bacteria, which is what one would expect, and really a low relative abundance of lactobacilli and really only inners sitting there. When we look at our male samples, they were far more heterogeneous, but there was an abundance of the BV bacteria at both sites. And you can see here that Gardnerella vaginalis, which is purple, is really only abundant at the urethral site, which fits with data from our other studies. It tends to be more intraurethral. And this is very important when we're thinking about therapies and thinking about the need to use a combination of antibiotics that target 2 anatomical sites. We saw a very significant decrease in the abundance of BV bacteria in the vaginal microbiota immediately after day 8, so exactly what we expected to see, and this was nicely sustained through to week 12. We saw again a very significant decrease in the abundance of BV-associated bacteria at both male genital sites immediately after treatment at day 8, and this was sustained through to week 12, although there was a less strong effect after we corrected for multiple comparisons. But collectively, these data were enough for us to proceed with a randomised controlled trial to determine whether concurrent oral and topical antibiotic treatment of male partners of women receiving first-line therapy for BV significantly reduces the risk of BV recurrence compared to what is our global standard of care, female treatment only in the 12 weeks after randomisation. Now, our primary outcome was BV recurrence defined as 3 to 4 AMSELS criteria with a Nugent score that lay in the range of 4 to 10 within 12 weeks. We had a number of secondary outcomes, so the same composite BV outcome, which is commonly used in clinical trials at 4 weeks, Nugent outcomes at 4 and 12 weeks, vaginal microbiota outcomes. We're in the process of DNA extraction for metagenomics on all of these samples, so that these data are not available for the talk, and adherence and adverse effects. So we started this trial just before COVID, and I'm sure many of you are involved in clinical trials and know what an absolute nightmare that was. And so the trial went from April 2019 to November 2023. Melbourne was one of the most locked down cities in the world outside of China. And this was a really challenging clinical environment for research. It was a multi-centre randomised open label phase 3 trial. We had trial sites at sexual health clinics and family planning services across 3 Australian states. Women needed to be 18 years of age or older. They were screened and eligible if they had symptomatic BV, met our described diagnostic criteria, had a regular partner for at least 8 weeks prior to enrolment, no other partners at enrolment, not knowing to be living with HIV, and not being treated for PID. Women could then refer their male partner, and the couple were eligible to participate if the male was also 18 years of age or older. They could enroll within a week of their partner They confirmed they had no other partners at enrolment and no contraindications to either of the antibiotics. Now, one of the challenges of really doing these studies, and they are extraordinarily hard studies to do, particularly because you're asking couples to commit to a 3-month trial that's quite intensive. But you often do these studies in STI services. And if you look at the other trials, they're all largely done there as well. And this is not traditionally your population of monogamous couples. So you need couples to commit to close relationships for 3 months, or you're going to have BV bacteria introduced from concurrent untreated partners and erode the intervention. And this is a really big issue that is very likely to have affected past trials. Female participants received first-line antimicrobial therapy. This was predominantly oral metronidazole for a week. We use 400 milligram tablets. You use 500 milligram tablets. There really is no clinically meaningful difference between the two. And a minority, a very small number, had intravaginal clindamycin cream if they'd previously not tolerated metronidazole. The couple were randomised 1-to-1 to the interventional control group, and we stratified this by IUD use and male circumcision status as our dominant risk factors. Our control group was global standard of care, female treatment. I can answer questions as to why we didn't have a topical, why we didn't have a placebo in this, but if you think carefully, rubbing a topical placebo product on the penis twice a day for 7 days is a very significant change to clinical practice for men or routine daily life for men. And you are going to substantially alter their penile microbiota on the skin, which is extremely likely to influence the endpoint. The intervention was concurrent combination antimicrobial therapy for males. This was, as I mentioned, 400 milligrams twice daily for 7 days with 2% clindamycin cream topically to the glands and upper shaft twice daily for 7 days. Our controls were told at the beginning they could have access to partner treatment if recurrence occurred. Now, we saw women on site at baseline week 4, week 12 for both AMSELS and Nugent scoring at day 8 and week 8. Adherence and adverse effects were assessed at day 8, and microscopists were blinded to group, and our study endpoint was BV or no BV within 12 weeks. So we were powered to detect a 40% reduction in recurrence. We aimed to recruit 342 couples across all sites, but we did build in a pre-specified interim analysis after 150 randomised couples to be undertaken by an independent data safety monitoring board with a very conservative stopping rule that could be applied if one arm was statistically inferior. Our primary analysis was a modified intention to treat analysis. Our evaluable population needed to have had at least one treatment dose and be assessed by AMSEL and Nugent criteria, our primary outcome. So we looked at cumulative recurrence rates per year, time to recurrence by arm. Cox regression was used to generate hazard ratios for our time to event analysis. We stratified our data by IUD use and circumcision status and summarised adherence and adverse effects. And Lenka Vostrasil, who's an epidemiologist who's been working with me for over a decade now, undertook all analyses according to a pre-specified published statistical analysis plan. So we actually assessed 357 couples for eligibility. 193 were ineligible or declined to participate. Now, this comprised of couples who couldn't commit or didn't want to commit to a 3-month trial, particularly during COVID, women who really didn't want to discuss the fact that they had BV with their partner or ask their partner to participate, and men who didn't want to participate. So 164 underwent randomisation before the trial was stopped at interim analysis by the Data Safety Monitoring Board for very significant inferiority of one arm. So we had 81 assigned to the partner treatment group, 83 to the control group. We had a small number of screening failures at sites that didn't have on-site laboratories. And then we had 80 in the intention to treat population and 79 in each group. We lost another 11 with some loss to follow-up, really mainly due again to COVID and challenges with getting in. and people leaving the state to go to less lockdown places. And we ended up with 68 and 69 in the modified intention to treat populations, respectively. So I won't go into details about our baseline characteristics of our eligible randomly assigned participants, but I will say that the majority of couples were recruited at sexual health clinics. 1/3 did self-refer from the community. We had a median duration relationship for our couples of 14 months and a median number of male lifetime partners for women of 15 and of female lifetime partners for males of 18 to 20. Now, just like our pilots, we recruited fairly desperate women who had multiple risk factors for BV recurrence, which in many ways is somewhat disheartening. A third, again, had an IUD in situ. 80% were uncircumcised, but this time nearly 90% of women had a history of BV with a median of 3 past episodes. But importantly, all risk factors were evenly distributed between the groups. So our Kaplan-Meier survival curve summarizes time to recurrence by group, and you can see this very nice, clear separation between the groups. So the partner treatment group at the top, the control group very rapidly experiencing recurrence. It was very striking. And it gave us a really nice hazard ratio, given the sample size of 0.37. And an upper bound of the 95% confidence intervals of 0.61, so well away from 1. We saw a reduced risk of BV recurrence in the partner treatment group versus controls for all of our secondary outcomes. So we can see 1 here. We can see our primary outcome here, which is our Amsels and Nugents at 12 weeks, the same outcome at 4 weeks, the same outcome, which is a per protocol analysis that required more than 70% adherence to medication, and our Nugent outcomes. Importantly, we also saw a reduced risk of BV recurrence in the partner treatment group versus controls in our stratified group. So you might recall that we stratified by IUD use and circumcision status. So we can see our hazard ratio for our modified intention to treat of 0.34 here. We can see that partner treatment was associated with a similar reduction in risk in IUD users as well as non-IUD users. The bulk of women in Australia are using the levonorgestrel IUDs. We had small numbers of coppers, but really significantly similar findings, not significant. We also saw a reduced risk of recurrence in both uncircumcised and circumcised men, but you can see again here that we had fewer numbers of circumcised men. Now, female adherence to treatment was high in our pilots and the trials, so more than 90% of women take all doses of everything. Male adherence was more mixed. They were really very good with oral metronidazole. So 84% took all metronidazole doses, and again, we saw this in the pilots. Where they tripped up a bit was with the topical clindamycin. So in the pilots, about 75% applied all doses. But in the trial itself, it dropped down to really only 56%. And this was a problem because if you look at this graph here and you can see recurrence rates per year, we've got, nearly 5 in our control group, 1.6 in our partner treatment group per year. And women whose male partners were less adherent, represented by these open symbols, had higher recurrence rates than partners who were more adherent. Obviously, everything's overlapping here, but these are signals. And really the take-home message was the lowest recurrence rate of 1.3 per year was seen in women whose male partners were 100% adherent to both medications. So this is a very important clinical message at the time of prescribing. Adherence has to be emphasized, particularly to the cream. Now, tolerability among treated men was excellent. We had the usual metronidazole side effects, actually at lower rates than women. And we had 4 cases of mild non-treatment limiting penile redness or irritation, exactly the same number in the pilots. And yeah, it was very minor. We did ask ourselves if topical clindamycin was so well tolerated, why was adherence lower for oral therapy in both our pilots and our trial? So we did some acceptability and treatment preference surveys in our males in the trial itself. Asher Dulab is one of our medical students who looked at our data for us. And these are some quick take-home messages. So if you ask them, 40% preferred the tablets. If you asked about ease of use, 60% said tablets were easier to take. But interestingly enough, if you asked them about taking the actual oral antibiotic, 87% said they found that that was easy, and 82% found using the topical antibiotic cream was easy. And in fact, 3/4 were happy to take both treatments for 7 days. 81% said that they had no difficulty synchronizing treatment with their partner. And 96% said that they'd take the same treatment again if needed. And 80% overall found it a positive experience, with 20% neither disagreeing or agreeing. So it was very acceptable to men. And all we could conclude was that it was just a bit more of a hassle to use the cream. And perhaps if you think about a busy day going out the door to work in the morning, you can pop a pill and swallow it with your breakfast, but you have to go back into the toilet and get the cream to apply it. So concurrent male partner treatment with oral and topical antibiotics greatly improved BV cure, and this was sustained over 3 months. It was well tolerated and acceptable to men, had a strong effect in a population with a very high burden of risk factors for recurrence. Female partners of men who adhered to treatment had the highest rates of cure, so that's a very important clinical message. And we really do need to improve male adherence, particularly for topical clindamycin, but there weren't any really obvious barriers to using it. So it's probably just as simple as having that discussion with them at the time of prescribing. Partner treatment was effective among women with an IUD and women with uncircumcised partners. So again, this is a really key message. You can try it for women with an IUD in situ. Obviously, we need an evidence base for IUD removal and retreatment, but it's a reasonable thing to do before you start considering that. Why did this intervention work? Well, we believe it's the combination of the oral antibiotic to target intraurethral BV bacteria and the topical antimicrobials to target the cutaneous BV bacteria that was key. And we addressed potential limitations of past trials. So we had an enormous emphasis on the need for close relationships and explained what happened if there were concurrent partnerships, and the potential for reintroduction of BV bacteria, the need for high adherence and avoidance of sex during treatment. So obviously the trials provided the first conclusive evidence to show that reinfection from partners is a significant driver of recurrence, and the evidence needed to confirm that BV is sexually transmissible. It's a paradigm shift in knowledge and clinical practice. But for us, it also advances our understanding of the pathogenesis of recurrence or treatment failure. And I'm going to go into this in the last couple of slides of the talk. But we learnt a number of key lessons along the way. It's really important to support women to discuss BV with partners, to engage men using inclusive and non-stigmatizing language. We talked about exchanging and sharing good and bad bacteria, and we used general analogies: having a drink, sharing food, shaking hands, kissing, etc., involving partners to improve cure and framing this as a shared responsibility. It's important to explain the intervention only works if everyone in partnerships receive treatment, everyone takes all of their medication, and you avoid sex during treatment. We put a lot of effort into developing resources because we realized there were a number of significant barriers, which included the fact that the vaginal cream is marketed, the clindamycin cream is marketed as a vaginal cream with applicators, and that it is a really big shift in clinical practice. We developed and co-designed these resources for clinicians, consumers, and pharmacists. They're available on our BV in Focus website for everyone to use. We're happy to share information for you to adapt any materials for your own client populations. We've done this with the New York City clinics who have translated the treatment instructions into 13 different languages. We've created information for consumers, for clinicians and pharmacists. I'll go through the decision-making tool and the partner treatment instructions, and there's a really nice video of the story, but also couples' experiences. So our general information obviously talks about BV, but we have tiles for individual treatment and partner treatment and frequently asked questions. Our partner treatment page stratifies information by whether the partner has a penis or both partners have a vagina. We put a lot of effort into information on how to talk to your general practitioner, primary health provider about BV and partner treatment and whether it's right for you. They can go to our Australian guidelines, obviously, but a lot of doctors are busy in primary care and their scope of practice is very broad. And we also put a lot of effort into how to have the conversation with your partner, because obviously this is quite a confronting thing, as any sexually transmissible infection is. It can result in blame. We created very simple information on instructions for the tablets and cream. We reverted to something called the fingertip rule, which is commonly used by dermatologists, which is a little easier than what we used in the trial, where we refer to an Australian coin size, which is not relevant globally. But basically, you do a squirt of cream on your fingertip to that first joint. If you've got a foreskin, pull it back, apply it from the tip of the penis over the glands into the groove. If you need, you can use a second squirt of cream and go right down to the base of the penis on both sides. There's really simple videos as well for people to use. We created a pharmacist letter because early on pharmacists were a bit pushed back on some patients in the community. We would get emails from around Australia saying this pharmacist won't dispense. And so again, if people need to adapt that, we're happy to share anything. So this is our decision-making tool, and this is available not only on our site, but also on the Australian guidelines. It helps clinicians think about the suitability of the person sitting in front of them for partner treatment and highlights that it really is most appropriate for ongoing regular partners with a penis of people diagnosed with vaginal BV who are being given recommended treatment for vaginal BV. Again, that it's most suitable for closed relationships without concurrent partners, but clinicians just need to use their judgment about the benefit where there are concurrent partners. So recommendations are stratified by presentation. So obviously we see a lot of patients who just have vaginal BV and casual partners with a penis in STI services, and there is no change to treatment recommendations. But it is helpful to talk about sexual transmissibility, and in particular that condoms provide protection. We've known this for 20 years. We ourselves published a meta-analysis on this around 2008. And so this is a really useful clinical message for women. Like all STIs, condoms afford a level of protection. Most women that you see that have a regular ongoing partner with a penis may either turn up with that partner or without that partner. Obviously, when they turn up with the partner, it's a little bit easier. You can have the discussion about all the information and give the woman the right treatment. And the key things that are important to talk about with male partners are really why two different antibiotics are being used, because they're targeting two different anatomical sites. Emphasize the need for high adherence to both treatments, the need to synchronize treatment to avoid condomless sex during the treatment, which you do for STI treatment, and obviously explain that it's less effective where there are concurrent untreated partners and when doses of either antibiotic are missed. Now, when the partner is not there, which represents the bulk of consultations globally, there are options. So, if STI services are comfortable and used to seeing men, so they may be able to be booked for a face-to-face or a telehealth appointment. But we also text women the website link that leads to all of this information. So all consumers can read all of this, and partners can turn up to their own practitioner, and the main information that you give the women is that don't start your treatment until your partner has obtained their treatment, or if you want to start your treatment, don't have any unprotected sex with that partner until they have accessed and completed their treatment, so that you know there's no interim risk of reinfection going on. Occasionally, you get men, particularly with the media flurry that we were not responsible for, who turn up. And obviously, that's a little more difficult. And the key messages really are to explain to them that the optimal time to treat them is when we know that their index, their female partner, has been appropriately diagnosed and managed. Treatment is synchronous and they've not resumed sex before antibiotic completion. So, in many situations, you really talk about rebaselining the couple, assessing the woman at the appropriate time, and then prescribing. Our male medication instructions are really nice and simple and self-explanatory, and there's a video as well, which is an animation. We did a cost effectiveness analysis, which was a really simple 12-month horizon with Jason Ong and Sally Zhang. And this was developed to represent healthcare delivery in Australia, but takes into consideration recurrence rates, treatment pathways, and all the downstream complications. But again, only over 12 months. Take-home message really is that it became cost-saving at 30%. Partner uptakes are quite low. And obviously cost effectiveness greatly improved with higher partner uptake. We did qualitative studies, which were semi-structured interviews with StepUp trial participants. The key themes is women feel really alone, stuck in a cycle of recurrent BV, bearing the burden of impacts. And for them, that is the physical impacts associated with repeat infection and the psychological impacts, but also the physical impacts of course after course of antibiotics. So we get occasional questions about antibiotic stewardship in men, but you have to look at what is happening to these women. If you look at their antibiotic consumption, it is extraordinarily high. And when one treats a male, you can break that cycle and reduce the female antibiotic consumption rate. With male partner treatment, they felt that it helped them deal with BV together and get everyone on board. And universally, men and women described a week of inconvenience as really minor compared to the inconvenience of repeated BV infections. So in conclusion, BV is common, highly recurrent, associated with significant sexual and reproductive sequelae and distress and impact on quality of life and relationships. Male partner treatment for BV obviously opens up new exciting opportunities for cure and prevention, and it is acceptable, well tolerated, and associated with substantial cost savings and improved health outcomes in the Australian setting. The trials demonstrated that reinfection is an important driver of recurrence, and it's confirmed that BV is sexually transmissible. So there's a number of resources to assist with patient information and prescribing at our website. Australian guidelines, the American College of ONG have issued a statement, and feel free to contact us if you want any information. Now, I alluded to this earlier because I do want to highlight that this trial has now finally created the opportunity that we needed to understand recurrence. And I put recurrence in inverted commas because this is this very loose umbrella term used to encompass repeat BV after treatment. But we all know we don't do routine tests of cure after treatment and prior to resuming sex. So there's actually no way of knowing if the woman sitting in front of you has been cured and then reinfected and recurs, or failed to clear her BV at all. We never expected this trial to be 100% effective because we always believed there were some women who themselves were failing to clear BV with the 5 to 7 day regimen of antibiotics. So the StepUp trial has demonstrated that reinfection is a dominant but not a sole driver. And we're looking at our data at the moment. So we've got about 188 treated couples from pilots, our RCT, and an open label extension study that do indeed identify a group of women in whom BV is treatment refractory. So if we look at their day 8 samples, BV is still there and before resuming sex, and unsurprisingly, IUDs are overrepresented in this group. So it does tell us that there are two pathways that contribute to repeat BV in women: refractory BV, that we can call loosely persister women, and reinfection, which is recurrence. So obviously we're going to need to start to address this in our management approaches if we're going to achieve high rates of cure for all women. So multifaceted approaches are still likely to be needed to achieve high levels of cure. Partner treatment is by no means the solution, the exclusive solution. It's just a nice new tool in our toolbox. We still have a little bit of work to do with this. As you've seen, we have to optimize adherence. It's quite possible some men may need a longer duration of therapy, and we need an evidence base for same-sex couples with two vaginas. For our persister women, we also need an evidence base. So we may need to look at trials of longer durations of therapy, combination therapy, agents to disrupt biofilm, studies of IUD removal, and adjunctive therapies that are going to promote an optimal vaginal microbiome. So this is where perhaps live biotherapeutics play a role. So on that note, I would like to thank everyone who's been involved in this program, in particular my little team here, and all of our collaborators and our sources of funding and the Australian National Health and Medical Research Council. And I will end.
Wonderful. Thank you so much for going over all of the data and especially for sharing resources for people because we have an audience, many of whom are practicing clinicians and in clinics every day and really looking for some of those practical kind of resources. I'm going to take 1 second to share my slide with some CME reminders for folks, and then we're going to jump into questions. Give me one moment. Okie dokie. All right. So, as I anticipated, we had a lively audience. There are a lot of questions for you. I'm just going to jump in. I'm going to start with there were a couple about some just study design and some how was the trial done questions. So, I'm going to start with those.
Yep.
So, question one is why did you choose topical Clinda instead of topical metronidazole? Was this availability or were you going for different mechanisms of action? What was the thinking?
Yeah, good question. We were going for slightly different mechanisms of action, but also if you look at metronidazole gel and clindamycin cream, the clindamycin cream product is slightly more suitable for use in terms of rubbing it into the penis than the gel. It's pretty marginal, but it was different spectrums of activity as well.
Got it. Okay, so two things, practicality and also spectrum of activity. Great. All right, another sort of trial design question. And I couldn't remember this offhand, which I really should, but did you recommend against sexual activity for both partners during treatment? Was
Yeah,
that true?
very
Yeah, I thought
strongly.
so. Okay.
Yeah, we greatly emphasize that. So what we took, the three things that we took, well, perhaps I won't say three, but the things that we took a lot of care with was synchrony of treatment, no sex during treatment, and just emphasizing the impact that concurrent partnerships would have on the intervention when you need to do a 3-month trial. And this is a problem when you're doing a clinical trial. You have to retain couples in the study long enough to measure an outcome and
Hmm.
not too long for them to break up and not too long for them to have concurrent partnerships and the whole thing. It's extremely,
Yes,
extremely challenging trial to do. And what we said for couples was if you are going to have concurrent partnerships, your questionnaires that they're doing individually are completely confidential. Please just document it, and then we will be able to understand why the intervention may not have worked.
I see. So you encourage monogamy, you encourage abstinence, but you had a mechanism for folks to let you know if they went another route.
To a
Awesome. Okay.
degree.
Okay. I have another question related to kind of trial design and choices. This has come up for me too. The way your study was designed in terms of diagnosing and confirming BV was obviously very rigorous, using both Ansell's criteria and Nugent's criteria. And somebody in the Q&A is asking about how you would think about nucleic acid amplification tests as a way to diagnose BV,
Yep.
especially in sites like where microscopy is not available.
Yeah.
Sometimes clinicians are
Yeah.
just providing empiric diagnosis and management. Would you feel good about using a BV NAT and then providing partner therapy?
Yeah, yeah. And that's an important question because I work in an STI service that sees about 60,000 patients a year and has an on-site laboratory. And every woman with vaginal symptoms, or PID symptoms, has a wet preparation, a gram stain, and a bedside pH. That's our standard of care. That represents what, 0.0001% of the population.
Yes. Yeah.
And so we're fully aware that this is not remotely reflective of practice out there. Now, and I sort of set that up 20 years ago when I started working in the field so that we can do clinical trials. The use of NATs all depends on the performance of the NAT. So I think we all say that to clinicians: know the test you're using, know its sensitivity, its specificity, ideally its positive and negative predictive value in the population. Obviously, tests perform often less well in very low prevalence populations, which is usually not the case for BV, fortunately. And so you're usually using a NAT in a high prevalence environment where performance is optimized. A lot of the commercial NATs do, in fact, have quite good sensitivity and specificity. But look up the publication and see, did they compare it to Amsels and Nugent's? They usually do have a nice table and give even in the abstract, often the performance metrics. So as long as you've got reasonable sensitivities and specificities in the 90s, then absolutely, absolutely.
Okay, so you'd feel good about it, but make sure you know what test you're using and
Yeah,
ideally
know
how it's
what tests you're
performing.
using because not tests are all equal. And this is the use of NATs obviously for women. We're not talking about men.
Got it. Okay, that's helpful. All right, we're going to take a different tract now. There are a couple of questions about around is BV an STI? Is it sexually transmitted? Is it sexually associated? Someone's asking, do the men get it from the women and then give it back to the women? Or is it more that there are this is how I think of it. So correct me if I'm wrong, but is it more that there's certain combinations of penile and vaginal microbiomes that when they get together, they result in dysbiosis? I'm just curious how you'd respond to
Yeah,
the STI
yeah,
question.
yeah. So, I think people do get really stuck on, and the media did, is BV and STI. It was
Yes.
quite divisive. Um, and so, I mean, when humans interact with each other, they exchange viruses, bacteria, and fungi, and there's nothing more intimate than sex. And if you actually study couples, we did a study many years ago. I know this is sounding a little tangential, but it is really relevant
Go
on
for it.
couples, same-sex couples with two vaginas. What we showed, and Jeannie Mirazzo worked hugely in this space, so she's published a lot on this as well in her previous roles. Um, Women's vaginal microbiota rapidly aligns. So they have very high concordance for BV or no BV. So we did a study of several hundred same-sex couples with two vaginas. We followed them for 2 years, and we showed that women who co-enrolled with their female partner who did not have BV at the outset and did not have other partnerships, did not have BV at the end, and women with new partners developed incident BV because the prevalence in that population is at least 30%. So the probability of encountering BV in partners, in female partners, was high. So what this told us many years ago is absolutely it's a transmission event, and it's people seem to have no difficulty in understanding vaginal to vaginal transmission, but really struggled with this whole penile concept. So the penile microbiome can't be classified neatly like the vaginal microbiome can into these nice sort of community state types. Seems to be a lot more heterogeneous and messy. But what we do know is these key BV bacteria are present both cutaneously and intraurethral, that perhaps there is a bit of a tropism for Gunnarella vaginalis to the intraurethral site, um, and that they are exchanged. And that they are exchanged during sex. And in fact, carriage of these BV bugs in men is probably actually quite high if you think the prevalence is so high in women. It doesn't seem to be associated with a really obvious clinical syndrome in men, but in fact, as a clinician who's been working in this space for 20 years, and I'm sure many people on the call are familiar with the male who has a foreskin and that sort of slightly boggy, puffy, smelly sort of glands and sulcus. So I think that there is a sort of much milder clinical syndrome there for some men. But is it just sexually associated? There's so much data on this. In all of our trials, we looked at this very early on. If it's just sexually associated and due to the act of sex itself, then frequency of sex would be associated with BV. And it isn't. It's the partner, not the frequency. So in all of our analyses in previous trials, we adjusted for frequency. And it's not just a pH effect from semen that normalizes fairly rapidly. And pH changes in BV are due actually to changes in lactobacilli and lactic acid. So it was a roundabout way of bringing in some data, but the term sexually associated is really ambiguous and it leads to a lot of confusion for women. What does that mean? Every time I have sex with someone, I'm going to get BV. Um, there is evidence for protection with condoms. There is partner specific evidence, but frequency is not associated with it. So I think it's just better to be very clear with women. I feel like we do women a disservice by saying we don't really know what causes BV. Here, have another course of antibiotics. We've got some really good evidence now that reinfection is responsible for a significant proportion of repeat BV, and that partner treatment can only work by preventing reinfection. There's no other way it can work. If you're going to shown by a randomized controlled trial that treating a man reduces recurrence in a women, then you're preventing transmission of something. But we tend to call it transmissibility rather than an STI because an STI seems to be quite polarizing.
Mhm. Yes, and that was also a point being made in the Q&A that it sounds like as you're talking, you sort of are leaning more on if we have to call it something, it's sexually associated is too confusing and maybe sexually transmissible is the right word.
Yeah,
Am I summarizing
yeah,
that properly?
yeah, I do. I mean, I think this is, I guess, something that's popped up a little bit. Less so in Australia, but there's been this discussion about stigmatizing women. And my answer to that really is it's far more stigmatizing to a woman to tell her you don't know why she's getting this. It's far better to give her the information that empowers her to make some decisions so that she has some agency over her body rather than attending clinician after clinician and being given the same course of antibiotics over and over again, plus or minus boric acid or suppression with Metrogel, none of which have been shown to work in the long term when you discontinue those products. So I think we have to be balanced about this, and so have a sensitive discussion that uses words like exchange, transfer, transmissible. We don't need to say STI. We should probably talk about chlamydia in this way as well. STIs discussions often blow up relationships.
That's a great point. But language kind of matters and it's good to be thoughtful about what words you're using with patients. I think in the end, you're making the same point as folks in our Q&A are as well. All right, I'm going to find some more questions for you because there's a lot. Okay, this is a good one. It's an important one. It's been coming up in the United States quite a bit. The question is, first BV diagnosis. Since your study really primarily focused on people with prior recurrences, I think it was something like what 87% had had a prior episode of BV or something. So that's the question. Because I'll
I
just tell
love
you in the US, it's kind of the individual groups are putting out a number of different guidances, like our ACOG, American College of Obstetrics and Gynecologists, they went pretty big. They leave it open. They sort of like imply that you could use it with a first episode of BV.
Yeah.
California's guidelines are a little more, maybe on a case by case basis, but in general, sticking to the trial criteria. So I'll stop talking and just kind of see how you would respond to
Yeah.
that first episode.
So this is a really important question. So, and one that I would really like to address. So the trial wasn't designed to address recurrent BV, and perhaps our emphasis it was to prevent recurrence, but it wasn't to recruit women with highly recurrent BV. The problem is when you ask someone to participate in a very onerous study and to agree to be randomized, you naturally get highly motivated women who have a history of problematic
Mhm.
BV.
Mhm.
These are
Yeah.
not the women you want in your trial. I didn't want them in the trial. As a clinician, 20 years ago, I sat there listening to woman after woman saying to me, I've just got this awful discharge and smell. I've just hooked up with this guy. I don't know what's happened to me. Or I've just got this back again. I haven't had it for 2 years, and my boyfriend's been overseas for 2 years, and we've just got back together again, and I've got it now. So it was this clinical experience that actually really got me thinking about this, together with doing some cohort studies and just constantly finding women with an ongoing regular partner had more than double the risk of recurrence. You couldn't adjust it out of any of your analyses. And every trial we ever did that treated women but did not improve, we did not improve cure with female only treatments, and regular partner kept being associated with failure. The women you really want to treat are these first timers before they have an established biofilm, highly recurrent BV, other factors that are making it harder and harder to treat. You want to terminate this infection at the beginning. So we treat first timers and we treat recurrent women, but the highly recurrent women have the lower cure rates than the first timers. So I think by restricting recommendations to women with highly recurrent BV, you set yourself up to fail because you get a larger group of persistent women. And at the moment, unless you're testing women straight after treatment before they're exposed to their partner and getting a sense of who is really failing to clear, then what do you do with your women? You just like people email me and say, do I just keep retreating the couple? You have to start to try and disentangle the pathogenesis and separate women who themselves are failing to clear for host and pathogen factors versus those who are curing very successfully and being reinfected. So obviously we're very early in this journey, and as a clinician, it's really hard, and we're setting ourselves up for our next phase of studies to try and address this. But the trial has actually been misinterpreted in a way as this is only an intervention for women with highly recurrent BV. And that is not the message we want. And perhaps the College of ONG, I think I gave a plenary at ITSOG or something, perhaps they had an opportunity to hear some of this, which helped them sort of think about that. But the women in the trial, also another area of misunderstanding was sometimes people have framed it as you're eligible for male partner treatment if you've had 3 recurrences in 1 year. And that wasn't part of the trial either. This was ever. Most of them were over recent times, but it was ever. It wasn't, in the last year. So I think if you only use this intervention for women with extremely recurrent BV, you're going to get a lot of IUD users in that population. And you're going to have a lot of factors, male, female, and pathogen factors that might actually mean this relatively simple intervention is a lot less effective. So I hope that sort of answers that question.
Yeah, it does. It's interesting to hear you talk about it. Like, oh, we actually weren't really going for people with highly recurrent
No,
TB,
no, and
but those are the people who would show up to a trial. I think that makes a lot of sense. I hadn't thought of it.
and I think James Schwebke, Jack Sebels, and Christina Musney's RCT did choose women with highly recurrent BV. They had a definition around it, but when I was designing our trial, I was like, these are not the people you want. So we
Hmm.
were thinking we weren't going to get them. But, as I said,
But
for
you
those reasons,
did.
yeah,
I see.
desperate women.
Okay, there have been a couple of questions, and it came up in your answer just now about IUDs and what role they play or don't play in
Mhm.
BV, and whether certain IUDs might be more risky for BV. Can you speak to that?
Yes, we're in the process. In fact, after this meeting, I'm on a trial meeting designing an IUD trial. IUDs are a problem. There's lots of evidence for copper IUDs. So that's where we have fairly irrefutable evidence that coppers are not good for your vaginal microbiome. Um, there may be a foreign body effect as well as a bleeding effect because some of these BV bacteria particularly like iron and heme. And so blood facilitates their growth. And that's where this sort of myth around you get BV from menstruating comes from. You don't get BV from menstruating, but it's like a nice culture medium for BV bugs to grow in. So they tend to flourish and women become symptomatic. We don't have an evidence base for levonorgestrel IUDs. Our data suggests that they are not good. Our clinical experience suggests they're not good, but we just don't know how not good they are. Are they as bad as copper IUDs? Are they sort of intermediate? And this is very important because oral contraceptive pills are associated with a very favorable microbiome, much more stable lactobacillus dominant microbiota. NuvaRing oral contraceptive pill likely to be the estrogen. The estrogen promotes glycogenization of the vaginal epithelium, which is the food source for lactobacilli. So again, like a culture medium, you're creating a more optimal environment that promotes a stable lactobacillus crispatus dominated microbiome. Um, and so all contraception is not equal. Contraception is given to women to prevent pregnancy without any consideration of the impact on their vaginal microbiome. And I have a real issue with this. And I think we need to create an evidence base for this. So in clinical practice, you will see overrepresented women with IUDs coming in with treatment refractory BV because there isn't evidence for screening prior to insertion in terms of in terms of prevention of recurrence, and there isn't any evidence base for removal and treatment and reinsertion. It's all a sort of bit of a black hole at the moment, and we're hoping to address this. But what I would say, and that's why I emphasize that in the talk, is that at least we know for a substantial group of these women, male partner treatment works. But what do you do when you've tried it and the woman is treatment refractory? We are removing and treating sort of individually. We don't have enough data to say that this is the right thing to do. And it's a big thing to take a woman's IUD out. So we're quite reluctant to do that. But it is a logical, appropriate strategy when you've tried everything else.
Makes sense. Okay, thanks for speaking to that. Now let's get back to the men. Wow, there are still questions coming in. Okay, next question. I'm going to call out this person. It's from Dr. Ina Park, who I know you know, so that's why I'm saying her name. She says, "Thank you, Kat. We are so grateful. Right now at MSHC, for men who self-report that their female partner currently has BV, Are you requiring that woman to come in for a vaginal exam even if she's already been diagnosed by her GP? What are your
Yeah,
thoughts?
it's a good question. At the moment, we've been getting, and it's really nice. We've been getting men of female partners who we've diagnosed. So we haven't had anyone wandering in from the community yet.
I see. Okay, so it hasn't happened yet.
It hasn't happened yet. So, but you've got to cover every possible scenario. What I would say is that all the men that I've seen come in and they've already read all the information. So they're completely up to date. And I say to them now, where's your partner at? Oh, she's got her antibiotic at home. She hasn't started it. She said, I had to come here first. So obviously we're seeing an optimal group, but that shows you how well it can work. This intervention is always going to work best in couples with open communication and closed relationships, but it does work beautifully in that situation. Um, for a man that wandered in off the street, so to speak,
Yes.
where
Yes,
we don't
that's the scenario.
where we don't know anything about the female, you feel very reluctant because in the absence of a diagnostic test for men, which we will be working on when our metagenomic data comes back. So at the moment we're working blind. When we have tests for men, that will change the situation. But um, really, I wrote this in the guidelines. It's really important to have an open discussion with that man about the futility of just giving him a course of antibiotics when we don't know really what the index has had, whether she was properly diagnosed. So our preference very much would be in the absence of being able to confirm it. I mean, you can ring he can ring the female partner and put her on speakerphone and she can say, I saw this doctor, I had this diagnosis, and I'm on day 4 of my metronidazole. That would be enough for us to be very happy to prescribe. But in the absence of being able to really know what's happened to her and where she is in her treatment and whether they've had sex again after she's completed treatment, I wouldn't be comfortable prescribing. I would actually ask them to come back together when it was convenient.
I see. So you'd feel uncomfortable essentially of just going ahead and
Yeah,
treating
I mean,
some,
my other hat on is antibiotic stewardship. So
right?
no, it's not that we want to use lots of antibiotics in men. There've been enough trials of just oral metronidazole in men, many in the US, which has a far lower rate of male circumcision, a far higher rate of male circumcision, and it doesn't work. So, I think it's pretty clear that we need combination therapy, but I think that it's very clear that women are bearing the burden of chronically high levels of antibiotic consumption, and that we can terminate that cycle for a very significant proportion of them by a 1 week course of combination therapy for men. So, yes, sure, they don't have symptoms. They're being called in, they're being asked to take antibiotics, and that's not ideal in a society where we're running out of antibiotics. But you have to think, what are you doing for that female? You're actually stopping those endless medical appointments, futile, repeated courses of antibiotics for her.
Got it. You spoke to something there that reminded me of something that I wanted to ask you, which is around antimicrobial stewardship and the scenario now. Let's say somebody has a female partner, but not in a monogamous relationship. Let's say they have had 5 partners in the last month. Like, would you advocate for trying to treat all of their male partners in that scenario?
Yeah, so you're talking about multiple male partners
Yes, which
for
I understand is not what the trial design was and not what was studied.
no.
I'm just curious what your practice
Yeah,
was.
so we did agree outside the trial to treat triads.
Triads. Okay.
You have people in scenarios where they have a regular partner, um, and then they have another regular partner, and often everyone sort of knows about each other, and that's fine. That's a perfect situation where you can bring people in and treat people. Um, I was thinking actually we did it less though for males. It was more two women and one male, I think, from memory. But anyway, just whatever the scenario is, it's all about capturing individuals in partnerships. But obviously, the more partners there are, then they have other partners, and the whole thing starts to become a bit ridiculous. So it really is most suited for units of people that don't
So
have
sort
lots
of
of.
ongoing relationships,
Yeah, usually there's
not
one
like
other person there, and that's yeah, that's sort of suitable for that. I think this is an interesting point because people get also very stuck on this. It's like, well, we need to know if it works in non-monogamous relationships. I've seen this written around the place. Would you expect that partner treatment to work, if you're treating a couple with chlamydia and there are two untreated partners floating around, of course, reinfection is going to occur. It's just the same biological sort of situation. I think where things are a little different is the population prevalence of chlamydia is like 1 or 2% in many populations, not all. And so your probability of encountering chlamydia or conversely, not encountering chlamydia with a casual partner is like 98%. But, we're thinking that carriage of BV bacteria in men is actually quite high if the prevalence is so high in heterosexual women in many settings. And so the probability of encountering these bugs in a casual partner becomes much higher. And obviously, if someone's an ongoing partner, well, the same applies for chlamydia, gonorrhea, and BV. Duration of carriage is an important consideration. We all know clearance for bugs occurs at different rates and at different anatomical sites, but I think persistence of these bugs seems very likely, long duration infections. And there may
that.
be things that facilitate that, like a foreskin facilitates long, high loads, long duration carriage. You're more of a super transmitter.
Super transmitter. Oh my, that doesn't sound good. Okay, back to people with penises, and I know we're getting short on time here, so I'm going to try to get through a few more, and then I'm sorry to folks who we didn't get to your questions. We left so much time, and yet it's never enough. Okay, your question, Dr. Bradshaw. People had a lot of questions about, does the male actually need to come in? Could this be expedited partner therapy? The question is, what are you doing at the evaluate, like practically, what are you doing at the evaluation of the penis having partner when they come in for the visits?
Yeah, so I guess the first point, obviously, expedited partner treatment is governed by legislation. So I would not personally feel comfortable giving a woman a week of metronidazole and a week of clindamycin to take home to the male partner without speaking to the male partner. That would be something, and our legislation wouldn't allow that, so we don't do that. Um, but it's very amenable to telehealth with a male partner and an e-script. So you can just send your script electronically. So you've had that discussion, you've assessed them for any symptoms and antibiotic allergies and contraindications and all of this sort of stuff. Um, for us, when the men come in, it's 5 minutes. Like they're universally, guys in their 20s to 40s, they're not on any medications, they don't have any medical conditions, and it's just really super quick. So it's a really nice and easy consultation once you've started doing it. You've got over that barrier that we all need to as clinicians to some new clinical practice change. Um, but it's quick and it's easy, very suitable for telehealth. So we did telehealth during the trial for some men. So super easy. But I think as a clinician, having that discussion is important, particularly when we also know adherence is it's an intervention that's very sensitive to adherence, which tells us, I think, we're probably only just hovering on the threshold of efficacy. If missing doses results in
Mm,
increased recurrence, we may
mm.
need duration therapy. So I view this very much as we've made great inroads, but it's not the end of the story. There may be some benefits from topical metronidazole instead of clindamycin. There may be longer duration therapies needed, would be more effective Some men may be super transmitters and need longer duration therapies. And I'm waiting for our sequencing data to sort of help us understand, is there a penile microbiome that's predictive of recurrence in women? That will help us understand
Mm,
on the therapies that we use in men.
got it. And on that note, I think I'm so sorry for the audience because we still did not get through all the questions, but we answered a lot of them. And I know we are at time and you have your meeting to get to, Dr. Bradshaw. So I just want to thank you, thank you, thank you again. You've been so lovely to work with. This was an excellent talk, and we appreciate all the time you spent answering questions here. Hopefully, we'll
No,
get to have you again sometime. Thanks
no,
again.
thank
And thank you,
you.
audience. That's
Okay.
all.